Hello, everyone. My name is Christine Bestvina. I'm a thoracic medical oncologist at the University of Chicago, and it's my pleasure today to speak about RET-positive non-small cell lung cancer, translating insights into targeted approaches. So, RET fusions occur in about 1 to 2% of patients with non-small cell lung cancer. This is a patient group that will experience brain metastasis frequently, with about 46% of patients developing CNS metastasis at some point during their treatment journey. RET fusions are found more frequently in patients with adenocarcinoma histology, in never smokers, and younger patients, particularly less than 60 years of age, as well as in more advanced disease stages, so advanced stage 3 or stage 4. We do know that patients who have RET fusions have a lower response to immunotherapy. And so getting access to RET inhibitors is particularly important for these patients. We'll talk about the efficacy and the favorable toxicity in a moment. But it's also that the patients who would be treated with chemoimmunotherapy or immunotherapy alone based off of PD-L1 expression just won't respond as well to those treatments as patients who do not have RET fusions. So, how RET fusions lead to oncogenic signaling? The RET fusion combines the RET kinase domain with a partner gene, causing constant activation of RET without need for external signaling. This is what drives continuous cell proliferation and survival, or oncogenesis. The way that RET inhibitors then can target that is that RET inhibitors will block the abnormal RET proteins caused by these gene fusions, or in other diseases, point mutations. This stops activation of downstream signaling pathways such as MAPK or PI3K AKT. As a result, cancer cell growth and survival are reduced. We are fortunate to have two different RET inhibitors which have shown significant efficacy as well as very tolerable side effect profiles. So the first is pralsetinib, and that was studied in the ARROW phase 1/2 trial. And here we saw response rates of 72% in the treatment-naive patient population group and 59% in those that had received prior platinum-based chemotherapy. That's really quite impressive and in line with what we've come to expect from, let's say, EGFR or ALK inhibitors. This drug is fairly well tolerated with side effects primarily of cytopenias, some hypertension, as well as a few incidents of pneumonitis. Then we also have selpercatinib. With this drug, we see a response rate of 83% in the treatment-naive patient population and 62% in those that had previously been treated with platinum chemotherapy. Here, the primary side effects to look out for include elevated AST and ALT, as well as hypertension. And then lastly, we had randomized clinical data from the Libretto 431 clinical trial that looked at selpercatinib versus platinum chemotherapy with or without pembrolizumab. And here we saw an improvement in response rate in the selpercatinib group over chemotherapy, as well as a very significant improvement in median progression-free survival. 24.8 months with selpercatinib as opposed to 11 months with the chemotherapy with or without immunotherapy, thus confirming that patients who have RET fusions really should receive upfront RET TKIs as their primary treatment of choice. So we know that unless, even while we have this excellent therapy, if we don't know about the presence of a RET fusion, we can't get the right access to the drug to the right patient. And so testing is something that's extremely important in particularly metastatic non-small cell lung cancer. Patients who have non-squamous non-small cell lung cancer should receive testing for EGFR, ALK, KRAS, ROS1, BRAF, NTRK, MET exon 14, HER2, NRG, and PDL1. And hopefully this list of targets will continue to grow as we get more specific in our science. But importantly, as it goes for RET fusions as well as other fusions like ALK and ROS1, RNA-based testing is going to have a much higher sensitivity than traditional DNA-based next-generation sequencing. And so, however testing is done at your local institution, it's really important to know and to make sure that RNA is a part of that testing algorithm so that we can capture all of these patients who have fusions. As we mentioned before, we're fortunate to have two options for patients who are found to have RET fusions in the front line. Those are selpercatinib and pralsetinib. Now, both of these are Category 1 recommendations by the NCCN. We may choose one of these drugs over the other based off of toxicity profiles. And so, as an example, sulpercatinib has higher rates of LFT elevation as a side effect, while pralsetinib has higher rates of cytopenias. So, if you have a patient who's previously had issues with their bone marrow, you may choose sulpercatinib. Whereas if you have a patient who has any sort of underlying liver issues, you may choose pralsetinib as the primary agent. Also importantly is that if the RET rearrangement comes back after the patient has started frontline therapy, so let's say the patient received a cycle of chemotherapy while some of the NGS testing was still pending, importantly, the NCCN does recommend interrupting that current therapy and transitioning to a RET inhibitor. And so, very important to keep an eye out for those NGS results as they come back. If you are not able to hold on starting treatment for any reason, if it's urgency or disease burden, important to know that you can interrupt that chemotherapy and transition to the RET inhibitor. When starting a RET inhibitor, it's really important to coach the patients on how frequently they're going to need follow up from both a lab and a provider perspective. And so we'll go through both agents and what monitoring may be required. For pralsetinib, patients need a CBC monthly for the first 3 months and then every 3 months thereafter. That's to try to capture some of those cytopenias that can potentially occur. Additionally, we are awaiting some randomized phase 3 data from the Accelerate clinical trial that showed that there may be an increased risk in severe infections with the pralsetinib cohort. So important to counsel patients if they are starting pralsetinib on fevers, how to contact their providers should they experience a fever and other signs of severe infection. Patients also need a CMP every 2 weeks during the first 3 months. It's also important to check the blood pressure of these patients after 1 week of treatment and monthly thereafter, given that hypertension can be a significant toxicity. Selpercatinib is very similar in many fashions, so same CBC and CMP parameters for monitoring. Patients also do need a TSH every 6 weeks and EKGs, particularly in patients who have congestive heart failure, electrolyte abnormalities, who may be taking multiple QTC prolonging medications, and similar blood pressure monitoring after 1 week and monthly thereafter. Um, Hypertensive episodes that are significant, so grade 3 or 4, can result in dose interruptions, dose reductions, or even drug discontinuation, depending on the severity. And so keeping an eye on that blood pressure at all follow-up visits is particularly important. So, understanding mechanisms of resistance, and by that I mean the patient has progressed after being on pralsetinib or selpercatinib. The patient then gets a ctDNA plus minus a tissue biopsy, What do we see to understand the biology of why that RET inhibitor is no longer working? And we can really group these resistance mechanisms into three big buckets. And importantly, this isn't just for RET inhibitors, this goes across all of our targeted therapies. We can see on target resistance mechanisms, and by which I mean the solvent front G810 mutations, or other on target RET point resistance mechanisms. We can see bypass mutations, by which I mean MET amplification, BRAF V600E, EGFR activation, MDM2. Or we can see transformation, and that can be a transformation to either small cell or squamous cell histology. I personally do pursue repeat biopsies for my patients at time of resistance, because we have found many different interesting resistance mechanisms that can be very effectively treated with new targeted therapies or combination therapies. And so important to try to understand why these drugs are no longer working. Very reassuringly, though, as we saw in the frontline Libretto 431 trial, patients can be on drug for a very long time. The average PFS in that trial was 24 months for frontline selpercatinib in the study arm. And so, we hope that patients will get significant time and good quality of life while they're on these drugs frontline. Again, as I think has been a theme in this conversation, patient quality of life can be quite good while on RET inhibitors. And so we would like to lengthen that amount of time for as long as possible. This is time off IV therapy, away from frequent clinic checks, and oftentimes living, being active members of their family, working, doing all the things that patients care about. One of the best methods for prolonging time on RET inhibitors can be radiation. And this is particularly for patients who have oligoprogression or progression in 1 to 5 spots, let's say. We know that we can radiate those areas of progression, and patients can potentially continue on the TKI for many, many more months. Um, there are many emerging strategies that are under clinical trial investigation, including amivantamab plus RET inhibitors. We also are looking at the development of next generation RET inhibitors that will have significant activity against those solvent front mutations. And so lots to come in the RET space moving forward. And so, in summary, thank you so much for listening today. We have two exciting RET inhibitors that are available for patients, selpercatinib and pralsetinib. It is important to biopsy these patients at time of progression through liquid and likely tissue biopsy to try to understand the mechanisms of resistance. And if you do find a RET-based point mutation as the resistance mechanism, please consider referring your patient for a clinical trial looking at next generation RET inhibitors so that we can continue to move the science forward. Have a great day.